This talk will discuss the cardiovascular system and ways we can support that in critical care. So probably the most common reason a patient is referred to ITU is because they have low blood pressure, and the doctor phoning you will probably state that the patient's hypotensive and they think they need inotropes. Now, looking past the pedantic differences between inotropes and vasopressors, and that most patients actually need vasopressors, not inotropes, the question we need to consider is this patient in shock, and what kind of shock, and what can we do about it? So what is shock? Well, shock is a life-threatening state of organ hypoperfusion, a state of being unable to meet the metabolic and oxygen demands of the tissues. And to think further about shock, we have to actually think, what are the components of the cardiovascular system? And you can think of this a bit like Ohm's law in physics, where voltage equals current times resistance, where the voltage is your blood pressure, or your mean arterial pressure, the current is your cardiac output, and the resistance is your systemic vascular resistance. And further looking at the cardiac output is your heart rate times your stroke volume. So any one of these components, the heart rate, stroke volume, and systemic vascular resistance, can all cause disturbances in the blood pressure and the cardiovascular status of the patient. The three components of stroke volume are the preload, the afterload, and the contractility. So your preload is the volume of blood in the ventricle at the end of diastole, so the end of filling. And then afterload is the amount of blood left in the ventricle after systole, so after ejection of blood. And then contractility is the ability of the ventricle to contract under pressure in order to eject the blood. So the more the preload, so the more blood coming back into the heart and filling the heart, the higher your stroke volume, because this will actually increase the force of contraction via the Frank-Starling mechanism. And then the higher the afterload, so the higher the amount of blood that's left in the ventricle at the end of systole, the lower the cardiac output, because you're not ejecting as much blood. So your preload is largely determined by the filling status of the patient, that is the gradient between the venous return, or your mean systemic filling pressure, and your right atrial pressure, so how easy it is for blood to return to the heart. And then afterload is largely determined by your systemic vascular resistance, or the arteriolar tone that your heart is contracting against. And then contractility will be determined by the actual state of the heart itself, so whether there's any comorbidities associated, such as heart failure or ischemic heart disease, or anything that's currently going on that might be affecting the ability of the heart to contract, such as myocarditis or a sort of septic cardiomyopathy. So mean arterial pressure, this is something we talk about a lot, so we talk about MAP targets. And you can calculate the mean arterial pressure by multiplying your diastolic blood pressure by 2, adding it to systolic blood pressure and dividing that by 3. But helpfully, actually, the MAP is given on our monitors, so you don't have to do that. Now, the MAP targets we would tend to go for is we tend to target a MAP of 65 for the majority of patients. And this is because this is a balance between causing harm by giving too much vasopressors to drive to a higher target, and the lack of benefit you see in driving to a higher target, balanced against the risk of hypoperfusion by having too low a target. Now, there may be selected cases where we would tolerate a MAP lower than this, but that would be on a case-by-case basis. There are also patients where we would go supranormal on these targets. So, for example, neuroprotection, which we'll talk about in the traumatic brain injury session, where we're trying to drive the blood pressure in order to maintain cerebral perfusion pressure. Or vascular patients where they have an abnormal arterial system, so they rely on higher blood pressure to drive flow through these. Types of shock. As you can see, there's quite a lot. So you can divide these up by how they affect the patient. So things that affect your preload would be hemorrhagic shock, so bleeding. Quite obviously, you don't have enough blood to go around. Hypovolemic, so if you have inadequate intake, if you're very dehydrated, if you have excess losses, such as gastrointestinal losses, or burns, where you lose a lot of fluid through the skin. Things that affect your contractility, So this is predominantly cardiogenic shock. So a big MI, Takotsubo cardiomyopathy, myocarditis, or other forms of cardiomyopathy, and poisonings as well, such as beta blocker or calcium channel overdoses, will all massively reduce your contractility. Obstructive shock, so classically you think of tamponade and tension pneumothorax, but a massive PE can also cause obstructive shock because you're obstructing outflow from the right ventricle. And then distributive shock will affect your afterload, so such as septic shock most commonly, but also anaphylactic and neurogenic in the case of very high spinal cord injury. There's also this nebulous term of dissociative shock, which we're not going to cover in this talk, but this would be things like carbon monoxide poisoning, cyanide poisoning, or extreme anemia, where there's nothing wrong with your cardiovascular system, it's just the ability of your blood to transfer oxygen around, or the ability of your cells to use that oxygen, is affected. So how are we going to assess and diagnose our patient with shock? Well, obviously we're going to start with history. What's the main problem that's brought them in? Do they have any comorbidities or any history of problems with the cardiovascular system, such as ischemic heart disease or heart failure? If they had recent surgery on their cardiovascular system. We're going to examine the patient, so particularly looking at temperature, capillary refill time as a marker of peripheral perfusion. What's their blood pressure and the mean arterial pressure? What's their urine output? And you can do a straight leg raise as well, which is where you lift the patient's legs and you assess the cardiovascular system to see if there's been any improvement. Because by lifting the patient's legs, we're giving them a virtual fluid bolus, as there's an increased amount of venous return from the legs that then returns to the central circulation. So how do we manage this? Well, the management will obviously depend on the cause. The mainstay of treatment for hemorrhagic shock is giving blood and turning off the tap, stopping them bleeding. So that will often mean a trip to theatre. Hypovolemic shock, we're going to give fluid resuscitation. So this will mainly be crystalloids, but also we occasionally use albumin. The use of synthetic colloids now has completely gone. We don't use any of those anymore. Cardiogenic shock, so we're looking at drugs that are going to affect the function of the heart, and there's a lot of these. The most common ones we would tend to use would be things like adrenaline, enoxamine, and levosimendan. And then afterload, if you have reduced systemic vascular resistance due to shock, such as septic shock, we're going to use vasopressors. So again, the most common ones we would use would be things like metaraminol and noradrenaline. We also use vasopressin in severe cases, and terlipressin as well in particular pathologies such as hepatorenal syndrome and GI bleeds. So there is a massive hemorrhage protocol which is available on the Trust document management system. You can define this various ways, so bleeding at over 150 mils a minute, bleeding your half body volume within 3 hours or your full body volume within 24 hours. Obviously it's not very useful to measure that and do nothing about it. Essentially, if we're worried about massive hemorrhage, we're going to activate the major hemorrhage protocol and get blood and blood products and get busy trying to turn off the tap. In a trauma call where a patient's actively bleeding, they don't wait to see how much blood they're losing. They're going to actively resuscitate with blood products and assess the effect. Hypovolemic shock, the main fluid of choice would be crystalloids. So the most commonly used one at Aintree is Plasmolite. And then in terms of maintenance fluids, we tend to use Dexsaline with or without potassium, depending on the potassium. And we tend to choose a rate of 1 ml per kilo per hour as maintenance fluids. Albumin you can consider when you're giving large volumes of crystalloid. Try something else, see if it helps. In theory, it would remain inside the circulation better than crystalloid, but we know from research that that probably isn't quite the case. It probably doesn't stay in the circulation as much as we'd hope. There are some evidence-based indications for albumin, such as spontaneous bacterial peritonitis hepatorenal syndrome, burns resuscitation, and possibly in septic shock as well. We never would use it to improve the albumin level. You can't really transfuse albumin to increase the albumin level, and there's no benefit in targeting higher albumin levels. And we should be cautious in traumatic brain injury because there is evidence of harm from albumin when you have traumatic brain injury. And this is thought to be due to the fact that albumin is leaving the circulation and increasing edema within a damaged brain. It's worth thinking about cost. 20% HAS will cost £50 a bottle, whereas Plasma-Lyte costs £1 a bag. Normal saline's even cheaper, 50p. So distributive shock. Well, we're going to use a vasopressor. We're going to increase peripheral vascular tone. Things that we can give peripherally would be drugs like metaraminol and phenylephrine. So you can give them as a bolus. You can start infusion peripherally. And then once you've got a central line in, you can use noradrenaline. And then we would tend to add vasopressin in when we're on higher doses of noradrenaline. Other things you can try are terlipressin in selected indications, and then methylene blue as a sort of salvage last-ditch treatment. We have had some success using this. The idea is that methylene blue scavenges nitric oxide and reduces that disordered vasodilation seen in septic shock. Cardiogenic shock, we're going to use inotropes. So historically, dopamine was used quite a lot, which we don't really use anymore. Ephedrine can be given peripherally. It does have some inotropic effect, but is fairly weak. Other things we can use are drugs like dobutamine and adrenaline, phosphodiesterase inhibitors like enoxamone and milrinone, and then levosimendan, which is this kind of magical drug that claims to sensitize the myocardium to calcium without increasing myocardial oxygen consumption. So, going further from the history and examination, we have some other things that we can use. So all patients will get an arterial line, and with an arterial line you could measure the pulse pressure variation or the stroke volume variation. The idea being that if your pulse pressure or your stroke volume varies with ventilation, this implies that you're underfilled. So if your stroke volume variation is over 10%, then it might be worth trying a fluid bolus. Echo, you can use bedside echo. So you can look at your preload, so left ventricular end diastolic area, just how full the heart looks. Contractility, you can do a visual assessment of the ejection fraction or do some fancier measurements. And then you can also look at your afterload to a certain extent using VTI to measure your flow out of the LVOT. In terms of advanced tools we have, so Swan-Ganz catheters have kind of fallen out of use now. This is from the Pacman trial back in 2005 that showed no benefit and showed a 10% complication rate with their use, so we don't use them at Aintree. What we do use is the PICO, which is a pulse contour analysis machine which plugs into the arterial line and is calibrated using thermodilution. And this will give us some other numbers to play with, which we'll talk about shortly. So PICO requires a central line and a large arterial line, so that would be in the femoral artery or the axillary artery. And it's a larger bore arterial line than standard, and it also has some other bits and pieces on it, such as a thermistor to measure temperature change. There is another thermistor and injector cap that attaches to the central line, which allows you to inject cold saline during your calibrations to measure cardiac output via thermodilution. And once you've calibrated it, you can use the PICO to give you some numbers about the cardiovascular status. So the main thing it will give you is your cardiac index. This is your cardiac output divided by your body surface area. So it's a standardized number that allows comparison against other patients. It will measure your GEDI, or your global end diastolic index, and this is an index of how much blood is in the heart at the end of diastole. So essentially how full your heart is. It can also give you your ITBI, which is your intrathoracic blood volume index, and this is the volume of blood inside the chest at the end of diastole. We would tend to use GEDI, and essentially it gives you two options. One is the cardiac index low or is it high? Or is it okay? And if your cardiac index is low and your JEDI is low, you probably need to give them some fluid. If your cardiac index is low and your JEDI is low, but your ELWI or extravascular lung water index is high, this is a measure of how much fluid is in the lungs. You might want to give them some fluid, but you also might want to give them some catecholamines or some inotropes vasopressors. If your cardiac index is low and your JEDI is high, again, you probably don't really want to be giving them more volume, and it would depend on your extravascular lung water index whether you would just manage this with vasopressors or whether you might want to think about taking some fluid off. Again, if your cardiac index is over 3, there's another decision tree over that side. But again, if you're over 3, we're going to think about weaning stuff off rather than actively managing, usually, because it usually means we're heading in the right direction. So these are the things that PICO gives us and what it looks at. So your preload, you give you a stroke volume variation, and your JEDI, which is your global end diastolic index, and your extravascular lung water index that shows how much blood is in the heart and how wet the lungs are. Your contractility can be demonstrated with your cardiac index, and your afterload can be demonstrated with your systemic vascular resistance index. So depending on the values of these would guide us towards management. So some cases to discuss here. The first case is a 75-year-old female who has a past medical history of hypertension and type 2 diabetes, and she has had a long surgery with a maxillofacial squamous cell carcinoma resection with a free flap. So we see these quite commonly as post-ops on our ITU. They're cases where the patient's had a very, very long operation to remove a tumour from their mouth or head and neck, and then the defect has been filled with a free flap. So this is a flap of tissue, muscle, and sometimes bone that might be taken from the thigh, it might be taken from the latissimus dorsi muscle. And they commonly have had quite a lot of fluid, and they often come round just for a sort of bed and breakfast monitoring. They rarely cause many problems, but they can sometimes. In this case, her MAP is only 60. We're concerned about making sure we're maintaining normal physiology, because with a free flap, we want to make sure we have flow through that flap so it doesn't become ischemic. And often the first approach to this is we're going to give a fluid bolus. And the reason for that is they've had a long operation, they may have had losses that haven't been measured, and actually using vasopressors where you've had a free flap, causing vasoconstriction is probably not what you want to do to maintain perfusion to that free, newly plumbed in piece of tissue. But if they don't respond to fluids, obviously we want to make sure that they're perfusing everything, so we will have to use some vasopressors. I would just be careful in doing it. And commonly you'd start with some peripheral metronidazole, because often these patients don't have central line, and then you would progress to noradrenaline when required. Now, metronidazole does come as pre-printed on our prescription chart, so you can just sign it, but it's used as a 0.5 milligram per mil strength, and it can be given peripherally as an infusion. Second case is a 6-year-old man who's 80 kilos and is previously fit and well, and he's got a community-acquired pneumonia on his chest x-ray. And when he presents, his lactate is 8 and he's hypotensive despite 4 litres of fluid. So a very common presentation of septic shock. And there's lots of definitions around sepsis, and they seem to keep changing all the time. But in general, septic shock would be the presence of sepsis coupled with hypotension that's not responsive to fluid, or where you're requiring vasopressors to meet a MAP of 65. So you could argue that this guy has had 4 litres of fluid and he's still hypotensive and his lactate is 8, so he would definitely fit the criteria for septic shock. The Surviving Sepsis campaign would tell us that the initial fluid resuscitation should be in the region of 30 mils per kilo, which for most people is going to be about 3 litres. And so this guy has definitely had his fluid resuscitation, so it'd be difficult to say that he just needs more fluid and he'll get better. Our first line vasopressor in most patients would be noradrenaline. Now you need a central line for that. So if someone has a very low blood pressure, there's going to be a time delay in getting that central line in, getting the position confirmed, getting the noradrenaline ready and starting that. So we would temporize it by using a peripheral metaraminol infusion whilst putting in a central line, and then transition to noradrenaline afterwards. We'd use vasopressin as a sort of second line pressor. So when the patient starts to get on very high amounts of noradrenaline or they're not improving, we would consider adding vasopressin in at that point. We also will commonly give steroids, hydrocortisone 50 milligrams every 6 hours, to augment the adrenal response to sepsis. If someone is going on to vasopressin, I would ideally want a PICO put in at that point. Vasopressin is a very, very potent vasoconstrictor, and if we're doing it unguided without any form of cardiac output measuring, there's a risk that we're going to overdo it and cause peripheral ischemia or myocardial ischemia. And the third case is a 35-year-old female who's only 50 kilos, and she's had flu-like symptoms and chest pain with palpitations and presents in pulmonary edema with a troponin of 3,000. Now the differentials here, obviously there's something going on with the heart that seems very bad. She could have had an MI. It's uncommon in a 35-year-old, but it's something that we need to consider. With the preceding flu-like symptoms, we'd be slightly concerned about a myocarditis type picture. Now, depending on her stability, would depend on her management. If it's just pulmonary edema, we may be able to manage that just with non-invasive ventilation and diuresis or nitrates. If she's in cardiogenic shock, that's going to be a whole different ball game. So the priority here is getting her stabilised and getting an echo, because we need to know what's going on with her heart, and that's going to allow us to choose the management properly and select an inotrope appropriately. If patients like this aren't improving or continue to get worse, at Aintree we don't have any specialist cardiac input in terms of ECMO. The closest place that does that would be Wythenshawe, and so we would certainly be discussing patients like this with Wythenshawe to see if there was anything they could offer. When considering invasive extracorporeal treatments, they're not treatments in and of themselves, they are a bridge to something. So they stop the patient dying while something else happens. So that might be that it's a bridge to recovery. If she's got myocarditis, it might be that she is going to improve to the point where she gets better, in which case fine. It might be a bridge to a transplant or a bridge to revascularization of a blocked coronary artery. But if there's no treatment at all, and it's a bridge to nowhere, then often they'll be declined by ECMO.